This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Clinical Neuroscience, the 2026 edition. The paper is titled, Safety and Effectiveness of Bolt-Mounted versus Tunneled External Ventricular Drains, a Systematic Review, Meta-Analysis, and Trial-Sequential Analysis.
This is a topic that hits home for anyone who has spent a night on call in the ICU or VER. External ventricular drains, or EVDs, are arguably the most fundamental procedure in neurocritical care. We use them for everything from acute hydrocephalus to intracranial pressure monitoring in trauma. But despite how common they are, there's this persistent procedural heterogeneity.
Exactly, Dr. Aris. If you walk into any two neurosurgical centers, you might see two completely different ways of securing these catheters. Some surgeons swear by the traditional tunnel technique, where the catheter is passed subcutaneously away from the ventriculostomy site. Others prefer the bolt-mounted approach, using a dedicated hardware interface to fix the drain directly to the skull.
And that's the crux of the paper. For years, we've debated which is better. The bolt is often seen as more stable, perhaps easier to place in a bedside setting without a large scalp incision. But then there's the question of the infection profile compared to a long subcutaneous tunnel. This study attempts to provide some clarity using a very rigorous methodology.
Right. The authors performed a systematic review and meta-analysis, but they added a layer that we don't always see in these types of papers, a trial-sequential analysis, or TSA.
Let's pause there for our residents listening. Ilara, can you explain why the TSA is significant here?
Of course. In a standard meta-analysis, you're pooling data from various studies, which can sometimes lead to false positives, what we call type 1 errors, because of repeated testing as new trials are added. A trial-sequential analysis is essentially the meta-analytic equivalent of a power calculation. It helps determine if the current evidence is actually mature enough to be conclusive, or if the results we're seeing are just statistical noise due to small sample sizes.
That's a crucial point, because as the abstract notes, the relative safety and effectiveness of these two approaches remain unclear. We've been relying on conflicting data from observational studies for a long time.
And that's exactly what the study found. Despite looking at all the available literature, they highlighted a significant lack of trial-level evidence. When they looked at the primary outcomes, which for an EVD are typically infection rates like ventriculitis and catheter-related complications like displacement or hemorrhage, the data remains fragmented.
It's interesting that despite EVDs being bread and butter neurosurgery, we still lack that high-level randomized controlled trial evidence to say method A is definitively superior to method B. The procedural heterogeneity the authors mention isn't just about the bolt versus the tunnel. It's about the lack of a standardized protocol across the board.
The paper emphasizes that because the data is so conflicting, we can't definitively claim one is safer than the other yet. Some observational data might suggest bolts reduce the risk of CSF leak or accidental pullouts, while tunneling is traditionally thought to provide a biological barrier against bacteria. But without that trial-level evidence, it's all still up for debate.
So, for the residents and practicing surgeons listening, what's the takeaway? If the evidence is still maturing, as the TSA might suggest, we have to be meticulous regardless of the technique we choose. If you're using a bolt-mounted system, you're looking for mechanical stability. If you're tunneling, you're focusing on that subcutaneous path.
And more importantly, this paper is a call to action. It points out that we need well-designed prospective trials to actually settle the score. We can't just keep relying on retrospective reviews of how we've always done it.
Well said. The safety and effectiveness of our most basic tools should be backed by the highest level of evidence. This systematic review from the Journal of Clinical Neuroscience really highlights the gap between our clinical practice and our statistical certainty.
It's a great reminder that even in a field as advanced as neurosurgery, there's always room for more rigorous research.
Absolutely. That's all the time we have for today. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.